Okay, excellent. I think it's 2 minutes past 2, so we can get started, and then hopefully as more people come in, they'll be able to catch up. My name is Dr. Arina Tamborska. I'm a neurology resident. I am based in Liverpool at the University of Liverpool at the Walton Centre, and work quite closely with the Liverpool Brain Infections Group. You might have seen me in the previous sessions as one of the speakers, but it's been a delight for me to be invited to join the organizing panel and to host today's session, which is on building capacity in global neurology. And we have a jam-packed schedule today. We have first, I'll be introducing the chair, and then we'll have our speaker, Dr. Mashina Chomba. We'll follow that up as usual with a panel discussion and questions for the speaker. And of course, do make sure you stay for the end, because we'll be also talking about opportunities, research fellowships, and also upcoming conferences. So definitely don't switch off too early. So with that, I'm going to introduce our chair. Sam is someone who we are very pleased to have to chair the session today, because he is a good friend to our Liverpool team. But at the moment in his day-to-day job, Professor Nightingale is an associate professor of neurology at the University of Cape Town. His main research interest is on HIV and cognition and neuroinfections as well. And within that, he is a member of the HIV Cognition Working Group at the University of Cape Town. He is also a co-PI on the CONNECT study, which investigates effects of changes to antiretroviral therapy on the central nervous system. And he also has his own research program looking at the elements of inflammation and infection on Alzheimer's dementia. He might also have exciting postdoc opportunities coming up with regards to that work, but for today, we'll be focusing on increasing capacity and training for global neurology. Some special interest in that is also the fact that he is a co-lead of the NeuroAccess course, which is an initiative which improves training in neurology, and especially clinical neurology, and in different countries in sub-Saharan Africa. So that's something that Sam has co-funded with Professor Ben Michael from Liverpool. So I think with this introduction, I'm very delighted to hand over to Sam to introduce our speaker and kick off the session.
Hi, well, thank you very much, Arina, for that introduction. So yeah, thanks very much for the invitation to chair this session, and I'm really excited about the discussion today. I think it's going to be great. So I'll introduce the speaker, Dr. Mashina Chomba. Dr. Chomba is a consultant neurologist in Zambia, in Lusaka, and who was trained in Lusaka, and he's the first or in the first batch or cohort of neurologists trained in that country. And that's what we're going to be hearing a bit about today. And I first met Mashina probably about 10 years ago, when myself and Benedict Michael would go out as part of the NeuroAccess course that Arina mentioned, where we would provide short-term, just 2 to 3 week training in clinical neurology. And at that point, there was no clinical neurology training program at all, and we would do bedside teaching and give a limited amount of teaching. And Mashina was actually one of the junior doctors at the time in our classes. But since then, things have developed enormously, and there is now this enormously impressive neurology training program, and that Mashina's benefited from, and he qualified a few years ago as a consultant neurologist. And since then, he's established a research fellowship in neuroinfectious disease at Columbia University in New York, and is now an NIH Fogarty Global Health Fellow. And his research focuses on the epidemiology of neurologic disease, particularly multiple sclerosis in sub-Saharan Africa, which is people describe as being uncommon, but in fact, as it turns out, is rather more common than people thought. And in fact, Mashina has just stepped out of an MS conference in Kenya to give this talk, and is going to go back in once we're done. So thanks for taking the time out. So he'll be speaking in a few moments. I'm really excited to hear what he's got to say. I'll also, before he speaks, just introduce Dr. Diana Saylor, who's the panelist as well. Diana went to Cape Town. I went to Lusaka in Zambia in 2018 and established the neurology training program that we're about to hear about. And she's now the director of postgraduate training program in neurology there, and retains a connection to Johns Hopkins University in the US, where she trained, and she's an associate professor of neurology and director of the global neurology program there. And I hope we're going to hear a bit more about the global neurology program as well. She, as well as running the neurology training program, she's been establishing a teleneurology program and building a research program. Her research focuses on neurological complications of HIV infection, which is also my interest, and we collaborate a bit there, but also global health neurology and improving diagnosis and management of neurologic conditions in resource-limited settings, and particularly stroke systems of care. She has projects in Zambia, Kenya, and Uganda. And she's enormously impressive, and the work that we're going to hear about today is really quite inspiring. And as a result, has been awarded a number of awards. I wasn't aware of this until I did my research on Diana for the sake of this introduction, but she's received the AAN Marada Spirik of Neurology Award, the Neuro Idea Award, the Ted Burns Humanism in Neurology Award, the A.B. Baker Teacher of Recognition Award, the American Neurological Association Distinguished Teacher Award, and the Johns Hopkins Alumni Association Global Achievement Award. And I'm sure they're all extremely well deserved, because as you'll hear, it's really a very impressive body of work that we're about to hear about. So without further ado, Dr. Mashina Chomba, over to you.
Hello, good morning, good afternoon, good evening, everyone, from wherever you're joining us. I would like to take this moment to thank Professor Sam Nightingale for that wonderful introduction, and thank the Clinical Exchange platform for this opportunity to speak to you about my experience and our experience in Zambia regarding capacity building in neurology in settings such as Zambia, low to middle income countries. And my talk will set the tone for a discussion that we'll be having later, and we'll set the background for our experiences. So before I go into the talk, I have no disclosures to make for this particular talk, and I'll start off by giving a brief background about Zambia, that the country that we'll be discussing this experience from. It is a country in South Central Africa with a population of approximately 20 million people by the most recent census. It's classified as a low-income nation now, with a GDP per capita of 1,000 or so US dollars. And within this setting, we have a high burden of infectious diseases such as HIV, tuberculosis, and malaria, as many countries in the region. But we're also noticing a rise recently in non-communicable diseases. We have a low doctor-to-patient ratio of about 1 to 12,000, with most doctors focused around the secondary to tertiary level hospitals, leaving the primary level healthcare system largely served by clinic officers and nurses. And you can think of clinic officers similar to physician assistants, as they're referred to in some countries like the US. So having shared the background in Zambia and looking at the attendance today from countries all over the world in each continent, I did want to ask the audience just to give us an idea of how many neurologists you have in your country. So I'll give a very arbitrary range here, either 0, between 1 to 9, between 9 to say 50, or 50 or greater. So if you could just quickly select any one of those options that you think best applies to your setting, then we can easily have a discussion that's centered around that. So I'll just give everyone a bit of time to make their selection, and I'll be prompted once that's done before we move on. There we are. So according to what the results I'm seeing here, we have quite a huge proportion of the attendance in the category, the last category, D. So greater than 50 neurologists. So of note and interestingly is that there are no participants attending today from a country that has no neurologists, which is interesting. And the list represented is countries which have less than 10 neurologists. It's interesting, I say it's interesting because the time I started my medical training, it was a time in Zambia that we had no neurologists. So if this question was asked to me, say 10 years ago, as Professor Nightingale pointed out, my answer by then would have been 0 Zambian locally trained neurologists. To explain this a little bit, I'll go back to medical training in Zambia in general. So for the first 42 years after independence, which was in 1964, when the republic was formed, the University of Zambia School of Medicine in Lusaka was the only medical school offering medical training. And this was serving both undergraduate and postgraduate training. It was affiliated and still is affiliated with the University Teaching Hospital, which is the largest referral hospital in Zambia now, amongst 6 other referral hospitals. Well, I graduated in 2011, and at that time, we were informed that we just joined a total of 1,200 medical doctors in total in the country, for a population of about 20 million people. And so this was a time that was prior to 2018. And at this time, we had no Zambian neurologists in Zambia. And I mention in Zambia because I speak without any knowledge of any Zambians trained and living outside of Zambia up to this point. And there was no specialized care for patients with neurological disease in the Department of Internal Medicine, where I was posted at that time after 2011 graduation from med school. And there was no postgraduate neurology training program. And this was difficult for people like me who wanted to become neurologists and had to think about looking for training outside the country. We did have a lot of support, which we have to acknowledge now. As Professor Nightingale pointed out, we did have non-Zambian neurologists who were living in the country with us in Zambia and were really significantly contributing to helping out with the care. And these were neurologists from the United States of America. And we have Professor Tazanov from Russia, who has been living in Zambia since the 90s. And I'll just mention Professor Gretchen Bebek, who has been in Zambia since the early 90s as well. Dr. Siddiqui, who has been with us for well over a decade now, and Dr. Michelle Kabawasand as well. And we also did get a lot of visits from doctors from the United Kingdom through the Liverpool group, as mentioned by Professor Nightingale earlier. And a lot of neurologists did visit us from different facilities in the US. And this was the state of neurology care at that time. And given this background, again, from 10 years ago, so I did want to find out if everyone here, and probably looking at the responses from the earlier poll, I'm curious to know if there's a training program located in the country of your practice. So wherever you are right now, could you just let us know if you do? Or if you're not sure, you could still let us know with the third option. So I'll give everyone a time, maybe a few seconds to a minute to just select one of those options, and I'll read out the answer to everyone. Great, so results are in, and a majority of the responses here, yes, there is a training program available in many of these countries represented here today, which is great to hear, which is good. And a few, about 15% or so don't know, are not sure. So this was very much like the situation we were with prior to 2018 with no neurology training program. But as mentioned earlier, Dr. Diana Sela moved to Zambia in 2018, and we joined the 60 or so % that state, yes, there is a training program in your country. So in 2018, the training program was finally launched at the University Teaching Hospital under the University of Zambia. And I'll mention that this was a collaboration of many, many different factors. The University of Zambia approved the curriculum. This was a collaborative effort from universities supporting not only Dr. Sela, but all the earlier mentioned doctors from the US, the Zambia Ministry of Health that had to support our joining the program because I was employed by the Ministry of Health at the time, as well as my classmates and colleagues, and the Zambia College of Medicine and Surgery, which had to also help with the affiliations of individuals who had already completed their training and wanted to come back into the program at the time of its launch. Altogether, the program is structured to be a 5-year training program, and 3 years of internal medicine with the final 2 years of neurology is the structure 2 now. And we had one dedicated course coordinator, that was Dr. Diana Sela. She guided mostly the clinical training and teaching, but we had been supported by a wide variety of visiting neurologists from the US, the UK, as well as Europe, and they would provide didactic classes in person. And after COVID, these were also available online, which are available now beyond and outside Zambia to doctors within the region as well. And it continues to grow through this platform. There is also now a dedicated neurology service at UTH as a result of this training program. We have so far graduated 8 Zambian neurologists, including myself. That's a total of 6 adult neurologists and 2 pediatric neurologists. And 3 of our neurologists have moved out of the hospital, which we're very excited about, to help us expand within the country. And currently there are 10 doctors in training. 3 are expected to graduate this year. And we have now expanded to include 2 international students joining us from Liberia and Tanzania. We still have great collaboration with our colleagues and friends and teachers from outside the country who are still active members of the neurology service and the faculty in training and in practice. And there's a well-integrated system of welcoming back neurologists who are trained outside Zambia when they return to Zambia. And I'll mention a colleague now, Dr. Melody Asukira, who was trained at Cape Town University with by Professor Nightingale, who has been a part of our team since she graduated as well. To give an example of the impact of this training program and the capacity building and all this collaboration, I'd like to talk a bit about the encounters, neurological encounters in our practice. So I wondered if it's the same in your country. Why don't we ask the audience to share what the commonest neurological disorder or disease that you encounter in your practice is? So is it stroke, epilepsy? Is it MS, neuroinflammatory disease, neuroinfections, or any other? Before I share some of our experiences with these disorders. And again, once you make your selection, we'll get the results that I will share with everyone and continue with our discussion. Just give it a few more seconds. Okay, and again, we have a large, over 50% votes for stroke. And this is followed by epilepsy and some multiple sclerosis and neuroinflammatory disease, about 10%. Neuroinfectious is about 14%, which is tied with epilepsy. And 5 is other types of neurological manifestations. So we are mostly seeing stroke within the practice of our audience members, which is quite similar to what we observed as well. So we were able to show in after setting up our program that 43% of all neurological diseases at UTH that are treated at UTH are stroke. And I point this out because in 2012, prior to the setting up of this program, that's roughly 11 years ago, some great work was done by Professor Tazanov, who I had acknowledged earlier, who described the stroke characteristics and outcomes of patients admitted to our hospital. And at that time, before the dedicated stroke unit was set up, our in-hospital mortality was 40%. Similar work was continued after the collaborative efforts led by Dr. Diana Sela after the setup of the training program in 2021. A similar cohort showed an in-hospital mortality of 24%. So we saw that 2 to 3 years after setting up the neurology training center, we had nearly halved the inpatient stroke mortality. And I point this out as a potential observable impact of the training program that it had at UTH. And this is just one of many, many examples. I think we can see similar improvements in teaching, research, and a wide variety of local benefits of this training program. We hope to continue to expand the training beyond UTH, as I mentioned. We hope to continue to investigate unique epidemiology of diseases in Zambia, previously understudied population. One example is multiple sclerosis, as Professor Nightingale had mentioned, that we are now starting to learn more about. We hope that we could use the Zoom platform as well as our international students to broaden the training beyond Zambia to those and continue to support those countries from the students' original countries. Hope to establish regional collaborative centers of excellence, preferably even start offering fellowships amongst candidates from the region. And soon we'll be talking about the potential launch of a stroke center at UTH. If I was to share a few lessons in, as I conclude, would be that collaboration is key. This was an effort which took willingness from all our collaborative partners from around the country, around the world, as well as the students and the Zambian contingent of students that was also willing and motivated to get this program to work. And we could not do, neither side could do this work without enthusiasm from the other. There had to be a lot of adopting of strategies that best suited our setting, and understanding the demographics may be different from other centers which have had training programs for a while. And we clearly see how having a neurology center in the country with locally trained neurologists has a huge impact on clinical outcomes and epidemiology. In conclusion, I'd like to acknowledge a wide range of people personally that I've listed here, from the Dean of the University of Zambia, Professor Bebek, who was one of the most important launchers of global neurology as we know it today. Diana Sela, who has been at the helm of this program from its inception. Dr. Omar Siddiqui, who has been with us in the country for quite some time and who introduced us to Diana Sela. Professor Tazanov, Dr. Kiran Thakur was my mentor and continues to teach and help the program. Other doctors and professors who have been a part of this effort before the program, from Zambia and the University of Zambia, Professor Edwin Chomba, Professor Mpabalwani, and our visiting team of teachers from the UK that we continue to learn from and continue to collaborate with, and on platforms such as these and others, Professor Benedict Michael, Professor Sam Nightingale, Dr. John Williamson, and our collaborative partners in work and research, Dr. Michael Kavausan, Dr. David Bearden. The list is long and there's so many people that we wish to thank. And I'll stop here and open up for any questions. Thank you very much.
Okay. Well, thank you very much indeed, Mashina. That was fascinating. I thought we'll have a bit of discussion now, and I'll bring Deanna in, and it'd be really interesting to hear both of your experiences. Deanna, in terms of setting up this program and the lessons learned and the trials and tribulations of what must have been an extremely challenging project, and also Mashina in terms of being part of that project, being a beneficiary of it, and now being part of the group which are leading the future direction of neurology in the country. So Deanna, do you want to, and of course everybody that's in the audience, if you want to write any questions in the chat, or you can put your hand up and ask them out loud if that's your preferred method, and we'll go from there. So Deanna, do you want to start by telling us a bit about setting up this program and your experience, and what went well, what went badly? How has it been for you?
Sure, thanks so much, and thanks for the invitation to be here, and thanks to Mashina for a great presentation as well. Looking back, I wasn't really sure what to expect when we moved to Zambia. I wasn't really sure what we'd be able to accomplish with the program, and I have to say that it's completely exceeded all of my wildest expectations, to be honest. the thing that I find most ironic is when we were first getting ready to start the program, and along with the training program, we also started the first neurology inpatient service in the country. And I remember people saying, I'm not sure why you're doing this. We don't have that much neurology here. We don't really need neurologists. And we're not really sure that there's going to be anyone on your inpatient service. And now we are consistently either the first or second busiest service in the internal medicine department. We had more patients than we could possibly deal with. We started with just myself as the only full-time teaching faculty in the program, and then 3 registrars, and we usually had 50 to 60 inpatients on our service at any given time. And so it really, really was very, very busy, and people quickly realized just how much neurology there was once there were neurologists. I guess that old, if you build it, they will come adage. So I think that was, the biggest challenge was just the numbers of patients being very large, the numbers of me being very small, and the numbers of registrars being very small. As we've graduated registrars and they've become consultants and now are leading and contributing to the training program and the clinical efforts, that's gotten a lot easier. I think the other big challenges were just initially, working in isolation is really difficult. I really missed the colleagues that you could run a difficult case by or run into in the hospital and just say, hey, can you look at this image with me? So again, that's gotten better now that we have a group of fully trained neurologists and we can do that all the time. But I think the other thing that's really challenging is all the other codders that you work with, you depend on the neuro-ophthalmologists, neuroradiologists, physiotherapists, occupational therapists, speech therapists that we have either none or one of, in the country. And so kind of learning how to do a lot of the things that usually other services would do, and us kind of doing the swallowing training and swallowing evals on our own without speech therapists and things like that, I think was another big challenge and remains a challenge. But overall, I think just time and actually training people has made a lot of the problems go away, or at least less of a problem.
I mean, that's incredible that, you've managed to transform things from a point where neurology was considered either unimportant or uncommon, or perhaps both, to the point that you're one of the busiest services. And I just wonder, when you're doing two things, when you're developing a program which is educational, but you're also trying to provide a service, how you balance those things, and I guess how you prevent burnout, both for yourself, because you're having to be the only neurologist, at least when you started. I realize things are better now because you've trained other ones. But for yourself, you're doing the clinical service as well as providing a teaching program that you're having to set up from scratch, but also for the residents who who are obviously suddenly having to deal with a very large throughput. I mean, I've seen statistics saying which look like your kind of average neurology take there would be 2, 3, 4 times the size of what ours might be in when I work in the UK or here in Cape Town. So how do you get that balance right and prevent sort of burning out for you and the residents?
Yeah, and I think Mashina should speak to that too, because maybe I'm wrong. But I think, one of the good things, I guess, is that with medical training in general and neurology being no different, much of your learning is really at the bedside. And so I really didn't differentiate the clinical provision of care from the training. I thought those are sort of inexorably linked and intertwined. But we do also have a really robust, didactic curriculum with activities every afternoon. And I would say initially that was the major cause of burnout. Was not only was I trying to do all the clinical work, but all the teaching as well. And that has, gotten much better. When we would get visitors, I would take full advantage of them doing all the teaching in the afternoon. So that definitely helped when it was just me. Then we had other graduates who could also contribute to the teaching. But honestly, the best part of, or the biggest impact of improving that has been COVID, and starting to offer all of our lectures virtually. Initially, we did it just so that we limited our exposure to each other in a small room. But in realizing that we were doing things on Zoom, I realized I didn't have to give every lecture, and I could invite people from all over the world to give lectures. And so now we primarily have visiting lectures, meaning visiting virtually with us. And so I rarely have to give lectures beyond the ones I really want to give. And so that has made a big difference. So I think the keys were really collaboration and trying not to do things completely by yourself when you didn't have to. And then also, you know, we took advantage of online courses and courses that had already been developed and utilized those for some of our curriculum. And so I think the other lesson is not reinventing the wheel. If someone has done something already that serves your purposes, not being afraid to utilize that rather than feeling like you have to do it all on your own.
Yeah, that's great. There's a questions come in the chat here, but before we go to that, just to follow from that, I mean, you know, COVID's changed so much in terms of our use of technology, and I understand that technology's been something you've really been embracing into trying to push services out and to also, as you've mentioned, bring expertise in. Mashina, do you want to perhaps speak to that, and Deanna, you could perhaps follow. But you know, I understand there's a number of different programs which are using technology to improve things, and I think actually that might be surprising for people in high income settings. That you know, low income settings can embrace the use of technology. Places that might not have access, for example, to textbooks, often to medications are limited, other things, there's so much limitation, but actually that technology has somehow overtaken other aspects of development, and that internet connection and access to computers and smartphones is quite widespread, and so it can be a really useful tool in pushing this out and having greater impact. Did you want to, Mashina, do you want to start by telling us some of the use of technology that you've had?
Yeah, it was initially a planned effort to help out and expand services from the hospital in 2019 towards far-flung places which are very little access to neurologists, and a way to reach to people in different settings. When this was initially a pilot for offering teleneurology services that we partnered with a private company that was able to engage us and try to help set up the logistical technological side of things. And we were able to show that the neurology clinics could be had virtually through Zoom, through different video platforms, with a doctor in Zambia, one of us seeing the patient through a screen, and the patient with a doctor, a non-neurology doctor on the other side. This was a distance, a place as far as almost 1,000 kilometers from Lusaka, a bit rural, semi-rural, with internet access that was able to make us do this. And it just so happened to coincide with the onset of COVID the following year, which then made us change our strategy with clinics as well, because we had to shut down clinics at our hospital in Lusaka at UTH. And so we tried a similar strategy, and we're able to show that even outside a well-funded setting, with some of our patients that we're already seeing at UTH, we're able to still offer them the service because they couldn't come to the hospital because of COVID, in a similar manner as we did with this area that was outside Lusaka. And so there's a lot of teleneurology that has continued even after things have evolved in the pandemic. We still have patients coming in now, but we still have a few that we follow up within our UTH group of patients through teleneurology. That has helped a lot in terms of our reach. You know, we're a small group, we're growing, but that has helped us reach out. And Deanna already talked about the didactic classes and getting, circumventing some of those challenges that we had meeting the academic and clinical needs. And so with our Zoom, with our classes at the time, I was in my final year, when the COVID pandemic started, we had to switch our classes to Zoom. But this ended up expanding outside Zambia, and it was easier for people outside Zambia to join our classes that way. And the Zoom classes have continued. We now have a hybrid of classes with inpatient and Zoom being offered, with reaching out to a number of students outside Zambia as well. And we hope that this is something that we can use both to help the training within Zambia, as well as reach out to a lot of different areas outside the country.
So that's great. So really people can dial in on Zoom to the training program that you have, and I understand it's every afternoon. So you have didactic teaching, you have clinical teaching every morning and didactic teaching every afternoon in the program, which makes the Zambian neurology program already quite significantly superior to the neurology training I received in London. So there we go. But if people want to dial into that, I understand they can. And I think that it's a case of emailing Deanna and she can arrange the link to be disseminated. And perhaps we can put Deanna's email address in the chat. And so I understand there's also a tele-EEG service where you interpret EEGs virtually, as well as the teleneurology that you've mentioned, the online lectures that people can dial into. And then I understand that, Deanna, you also present cases to back at Johns Hopkins to the residents there. And I'm just interested to hear a bit about that in terms of, to what extent do you find that this is a sort of bidirectional learning thing, in that, it's not just Zambia benefiting from the expertise of people coming from Johns Hopkins or other high income settings? To what extent is it that people in those settings are learning from, the experience in Zambia?
Yeah, so I think that was really important to us, was to demonstrate the value, again, of that bidirectional partnership, and that what we see in Zambia can also directly benefit residents and neurologists in training in high-income countries. And so we started a global neurology morning report partnership with my home institution at Johns Hopkins, and every 2 weeks, either myself or one of our team members presents a case from Zambia to the group at Hopkins, and we walk through the the differences in resource availability and how that impacts our approach to both diagnosis and management of these patients. But I think we've actually evaluated the Hopkins residents' opinions of this series, and they find it to be one of the most valuable educational experiences that they have, and have said that, number one, it exposes them to conditions they otherwise only read about. And we've presented cases of manganism and lots of CNS TB and hydatid disease and things that they don't commonly encounter or may never encounter during training. But it also teaches them to be more aware of resource allocation, and that maybe you don't need to order everything that's available just because it's available. And we know that healthcare costs are a problem, not just in lower income countries, but also in higher income countries as well. And so I do think that these partnerships really have the potential to impact people, not just in the lower income setting, but also to impact practice and clinical approach in the higher income settings and provide valuable lessons for neurologists in those settings as well.
No, that's great. And that certainly was my experience visiting Zambia and other places, that I'm sure I learned far more than people learned from me. And it's back to real neurology. It's clinical neurology. These days you see the MRI before you see the patient, and that's certainly not the case in Zambia. So it really hones your clinical skills, I think, and teaches a different approach. Okay, so I've got so many more questions, but we'll perhaps go to the chat now. Could you, we'll link these two questions. So could you talk about how you set up the neurology curriculum, learning objectives needed to obtain neurology accreditation? Could the Zambian curriculum learning outcomes be adopted in other countries, and would it need to be adopted? And also there's a question here about how was the Zambian government supportive in that process?
Sure. So starting with the last question, the Zambian government has been incredibly supportive. My desire to start a training program was, I guess, serendipitously coincided with the Zambian government's focus on beginning specialist training in general in the country. And so they were very receptive to having a neurology training program. They actually pay all the salaries of our registrars. And so they have a financial investment in our program as well. So they've definitely been very, very supportive. I see there's a question about offering fellowships and scholarships. We don't have fellowships or scholarships, but if you're the Zambian citizens who pursue training do get a salary during their training through the Ministry of Health. And, it's interesting. Our curriculum, I think, looks very much like a curriculum that you have in a high income setting and we certainly emphasize neuroinfections more than many other places do. We emphasize nutritional neurological disorders more than other places do because we see those more. But otherwise, our epidemiology is not so different than the epidemiology that you see in other countries. As Mashina mentioned, MS supposedly doesn't exist in sub-Saharan Africa, but that's, I think, because neurologists don't exist many places. And when you put neurologists in sub-Saharan Africa, suddenly there's MS. And so I made a conscious decision that I really think that our trainees need to learn the most up-to-date neurology, just like neurologists in the US and Europe and other high-income settings need to learn. And then we do some very intentional adaptation of the information we've learned. So yes, it would be great to get a PET scan, but we don't have a PET scan in country. So how do we adapt that practice to the resources that are available? But I'm very conscientious of the fact that we're training the first ever generation of neurologists in Zambia, and they're going to be the ones moving the field forward, interacting with the Ministry of Health, advocating for more resources and more access to diagnostics and therapeutics. And if they're only taught about what is currently available in the country, then how do they move the field of neurology forward? And so we teach them the same things that you would learn in any neurology program anywhere in the world. And then we work in the clinical setting to adapt that to the resources that are currently available, always with an eye towards what would we do if we had more resources as well. And so I think that absolutely our program could be used as a model in other settings. And my hope is that it will be used. There's a lot of countries in sub-Saharan Africa in particular that may only have 1 or 2 neurologists. And starting a training program with yourself or just one other person is really, really challenging. But if we can provide the didactic curriculum for a program and this 1 or 2 neurologists just needs to do the clinical teaching during the clinical work that they already have to do, suddenly that seems much more feasible. And so I do hope, again, thinking about not reinventing the wheel, that as there are new training programs popping up, that our curriculum can help to support them as they begin to develop their programs as well.
No, and I think this is a model which I really hope can be replicated in other places, and there may well be people listening in who are wondering whether that something similar might be appropriate for their setting. So I think it's an incredible thing. And what hasn't been mentioned, I think, is that this was in Southern Africa, this really was the only neurology training program that existed, other than South Africa, where I'm sitting now. So really for thousands of miles, it was completely unique. And so, starting completely from scratch. But now I think, the groundwork has been laid. And so hopefully it's not a case of starting completely from scratch. I just want to ask, following from what you were talking about in terms of, the neurology training, learning about the kind of tests that might be available in high income settings, PET scans, etc., but also making things appropriate to the setting that people are working in. Mashina, I'd just be interested in your experience of training in neurology in Zambia, and then going to New York to train in neurological infection, which is quite interesting because you're probably leaving a setting where neurological infection is extremely common and going to one where it's certainly the types of infections that are being seen are different. How did you find? What did you find it? What were the sort of the strengths and weaknesses of going to New York compared to the training you'd received in Zambia? And is it something you'd recommend to other trainees in your situation?
Right. So my fellowship was a bit unique in the sense that it was a time when there was a lot of lockdown in New York because of COVID. So that was something which may have made my experience a little different. I did the entire fellowship online because of that, remotely. So that already is something maybe to factor in. However, I found my experience very beneficial. I found my experience with any setting out other than the one we practicing at UTH extremely eye-opening. There is a lot of So there's a lot that we adapt, that we do differently at UTH. There's a lot of innovation, if you will, with certain gaps and certain challenges that we've already highlighted. I find it easier to do that if you know how things should be, if that makes sense. If you know how things could be, if you know how, you know, what the gold standard would be considered globally, then it becomes, I think, easier for me when I'm back home in Zambia to know where I want to get and how to come up with a way to innovate and go there and overcome those challenges. I think it would be a bit unfair to ask someone to innovate something when they don't know where they should be going or what they should be aiming for, close to. So that to me has been the biggest benefit. It's really been eye-opening. I did get a chance to physically visit Johns Hopkins recently, and that coupled with my experience with colleagues from New York, that made it a lot. It kind of put the two sides of the coin, if you will, together. It kind of helped me understand what we are all working towards. And so I really do advocate for this bi-directional and collaborative efforts. There is a certain value in training in your home country, but there's also a certain value in seeing what the global standard is. So that to me has been the biggest highlight. Yeah.
Excellent. No, that I'm glad you find it useful. And I think at the end, which we're about to go to the slides promoting various programs, I think Arena has mentioned of a few possibilities for overseas training, including here at the University of Cape Town. We have trainees from a number of countries in Southern Africa, including, as you mentioned, Melody Asakile, from Zambia, who's actually sitting about 3 meters to my left at the moment, just out the other side of the door. Okay, so before we go to that, I see Ben has his hand up. Ben, do you want to go ahead?
Cheers. Yeah, thanks, Sam. I know we're tight on time. I mean, firstly, just huge congratulations to Deanna and Mashina and the team, because what you've achieved in Lusaka is nothing short of Herculean, and as we've heard, is, you know, a real beacon of hope and optimism and a demonstration of what can be achieved. And it's really, really wonderful, and it's been a delight to be one very, very tiny part of what you managed to achieve with Sam and others. What I wanted to ask in just the last couple of minutes we have is, you've touched on how technology has really advanced what's achievable in terms of education and international knowledge exchange and bidirectional learning. But you also mentioned the importance, and I think we'd all recognize this in our own training, of the bedside clinical teaching that we get and how valuable that is as well. And given what you've achieved in Lusaka, I wonder how, in addition to telemedicine, how you might see that rolling out in a hub and spoke model or something different to kind of reach out to the medical officers who aren't going to be neurologists, but there could be continuing professional development or something to help facilitate that communication. I think that's something you've been working on, but I'd love to hear a bit more.
Sure. No, I mean, those are great points. So I think we're doing that in two different ways. So one is, you know, medical students now rotate on the neurology service, so that the graduating physicians have had actual neurology clinical training. We also, all internal medicine registrars rotate on our service. We recently partnered with the new family practice training program, and the family practice registrars are rotating on our service. And so we are also helping to develop the neurology curriculum for the medical licentiates program, which is sort of this in-between between medical officers and clinical officers. And so we are starting to branch out beyond the doctor cadre as well. And so I think we're excited about that, and having people physically spend time with us. As Mashina mentioned, our graduates this year have both been posted to hospitals outside of UTH, where there are medical students and internal medicine training programs. And so now they'll start having that same effect there. And as we continue to have more graduates, we expect that they're also going to be posted to different provincial hospitals. And so we'll really be starting to increase access, both for patients, but also for non-neurologist doctors to neurologists for that essential neurology learning. And then the other thing that we're really excited about is that we welcomed our first 2 international trainees this year. So we have a trainee from Liberia and a trainee from Tanzania who've joined us this year. And in particular, the one from Liberia, there's no neurologist at all in Liberia right now. So he'll go back and be the first neurologist there. And we really hope to support him to develop a training program there. And we'd love to see that model where other trainees from countries in the region that don't have training programs can come for 2 years and train with us. So these are trainees who've already done their medicine training. They would come do a 2-year neurology fellowship with us and then return to their home countries. And we can again have a hub and spoke model of our training program for neurologists in the region as well. And we're really, really excited about that and hope that that continues to grow in the next few years as well.
Excellent. Well, there are a couple more questions, but I actually think they've been covered by that answer in particular about, improving diagnostic accuracy in rural African setups and getting some of your fellows to go out to more rural areas. So I think that's most of those covered, and we're getting out of time anyway. So with that, I'll thank both Diana and Mashina for fascinating insights and really an incredibly impressive program, and one that I'm very excited to see develop further. So thank you very much indeed, both of you, and thanks for taking time out of the conference. And I'll hand over to Arina.
That was excellent, and so many interesting learning points, and I'm sure also a future scope for collaboration, and particularly here in the clinical exchange platform. We do want to give a rise to new collaborations and bring those networks, and I'm sure that both Mashina and Diana would be happy to be contacted if anyone is here attending from any other settings which might need their own neurology training program. They'll be happy to advise. But with only 5 minutes left, let's move to the also, I hope, similarly exciting part of this meeting, which is about the opportunities, learning, research, and also the events that we want to promote. The first one actually is the fellowship that was already mentioned on the call. And it is the research fellowship in neuroinfectious diseases at the Columbia University, which is currently recruiting. And I think on the call today, we do have Dr. Kiran Thakur, Assistant Professor of Neurology from Columbia University. I'll just double check, are you with us, Kiran? Are you free to come in just to give us a 1-minute snippet and tell everyone why it's a brilliant program to apply for?
Yeah, sure. Thanks so much, Arina. And it's so good to hear about everything that's happening in Zambia and globally. It's really exciting to hear from Mashina and Diana on all the amazing work. So Mashina gave you a kind of a taste of this. This is, so during COVID, we pivoted to being a remote training program. And this is really to foster clinical research training globally for physician scientists and aspiring physician scientists from LIC and LMIC regions. And we've seen, I think, some key benefits actually, which parallel some of the opportunities that we heard about in Zambia. I think one, we've been able to support, which is our primary goal, individuals to develop their own local projects with support from the infrastructure that we have here, resources that are made available at Columbia, so that these trainees can develop their own projects, their own idea from the start, and then hopefully have the support so that they're able to continue it and lead it. So this is not a program that is kind of led by me. It's going to be led by future collaborators that are in these regions and leaders. And I think what we're starting to see is that we're developing, I think, real physician scientist leaders across the world. And now we have more funding available. So we currently have a trainee in rural Pakistan, as well as in Ethiopia, and we have an opportunity to have an additional trainee as well. It's remote. It can be part-time as well. The reason being, I think that we want to support the clinical activities that are needed to be performed by individuals who are clinicians in those regions. And so what I found is that this really supports individuals to kind of be able to preserve some of their time predominantly away from the kind of additional private practice that's often needed, so that we can provide a stipend of support, as well as all the other kind of things that we do. And then there's an opportunity you're able to tap into all our conferences here, our neuroepidemiology course, which is run through our Mailman School of Public Health. review the cases that we see. I will say, Mashina, we've learned more from you than I think we probably taught you. So I think there's really that bidirectionality as well. I think in particular for women who are interested in scientific careers, who have children, caretaker issues, I think this is really amenable to those individuals who I in particular want to continue to support in these regions. So please reach out. There's a lot of flexibility. Like I said, I think it's an exciting time because we do have additional funding to grow. So thanks.
Thank you, Kieran. And that's information on how to apply for that fellowship is available on the website link copied in the chat, and it will be an application to Dr. Tucker, and ideally by July 2023. So just very quickly, I'm gonna rush through the other opportunities. The next one, our World Federation of Neurology Fellowships, and also departmental visits, which are open to young neurologists who are nationals, and they also do reside in sub-Saharan Africa. And these are quite generous fellowships, which include travel to the place of your work, accommodation, living bursary, and also insurance for practicing medicine in those settings. There are openings in various centers, for example, in Cairo, in Egypt, also in South Africa, in Cape Town. But the one that is currently open is an epilepsy fellowship in Senegal, in Dakar. And again, in the chat, you will see a link, and that's the one with an application deadline in June. But this is something that is worth sort of checking on a regular basis. And the fellowships will be also available for other locations in Africa during the course of the year. Here, from our sort of perspective in Europe, I wanted to highlight the European Congress of Neurology, which is happening in July. This offers a reduced and grossly subsidized subscription and opportunity for virtual participation for neurologists and other clinicians based in the low and middle income countries. So joining for only 30 euros per year, you will get access to all the resources from European Academy of Neurology, but also virtual access to the Congress. For those neurologists who are in attendance today, and especially trainees who live in Europe, you might be also aware that European Academy of Neurology sponsors research fellowships, which will be opening on the 1st of July this year to go for a short sort of 6 to 12 months research placement in one of the other European countries. Just two more opportunities to mention. This exchange platform is closely related to the WHO IGAP on epilepsy and other neurological disorders, and there will be the first IGAP specific symposium happening in Boston at the Harvard Medical School on the 19th of July, and registration for virtual participation is free for that event. So this is, I'm sure our audience is much interested in the themes on how we expand neurological coverage, how we build capacity, and there will be a range of excellent speakers, including Nicolin Schließ, who is the head of the WHO Brain Health Unit. So that's definitely one to save the date for in your diaries. From Sam Nightingale, very quickly, a recommendation about EEG e-learning program, which was created in Cape Town with funding from the WFN, so World Federation of Neurology. It is free to sign up for participants from low and middle income settings. It is quite an intensive training, but an excellent resource to build skills in EEG, and also provides opportunity for certification at the end of it. And with that, I want to thank our funders and also invite you to the next clinical exchange platform, which is on the 30th of June, and we'll be looking at implementing WHO Neurology Revolution with a particular focus on epilepsy. And we have, again, excellent range of speakers from Malawi, Italy, and also from India. So do join us for that again. So thank you very much. Thank you to our chair. Thank you to our speakers. I hope today's session inspired you to new collaboration, inspired you to make new links, and hopefully it's another step in increasing care for neurological disorders globally. So thank you for your attendance.